Good morning everyone. This is a new topic, that is shoulder impingement syndrome rehab, the continuation of the first part of shoulder impingement syndrome. So again, take this for an example. This is your scapulae, this is your humerus, here comes your coracoid process, there comes your clavicle, ribs and the muscles of the scapulae which are passing through the subarachnoid space. The acromius is a abnormal shape, that is your hooked variant. Definitely there is impingement, as you can see in the image, thus leading to shoulder impingement syndrome. Talking down about the rehab part, there are two treatments, that is your operative and non-operative. Non-operative, definitely physiotherapy, that is your exercise therapy and adjunctive therapy. Second thing can be your medical therapy in order to relieve pain. Physiotherapy can be important to reduce pain, increase range of motion, gives strength, thus reducing the impingement. Operative treatment is usually, when you have a trauma to the rotator cuff, or you land up with an accident, or even in the abnormal shape of the acromion. You cannot help, the physiotherapy cannot help in that situation. Coming now to non-operative, that is your physiotherapy. Mainline therapy being the exercise therapy, that is to increase the range of motion, reduce pain, you can use the modality, and also manual therapy to be used if needed in order to give the arthrokinematics to the glenohumeral joint. The protocol which we are discussing today is Wilk and Andrews protocol for non-operative rehab of shoulder impingement syndrome. So Wilk and Andrews protocol is divided into phase 5, 1, 2, 3, 4, 5. First phase is known as acute phase, wherein maximal protection is provided to the patient. Second phase is known as motion phase, which is also known as acute phase, wherein being a therapist, we focus mainly on motion. Third phase, here look at the phases, we are not talking about the pain anywhere. Third phase being intermediate strengthening phase, wherein you start initiation of the strengthening protocol for the patient. Fourth phase being dynamic advanced strengthening phase, and fifth phase being return to activity phase. Coming down to the phases. First one, please make sure reading in a table, writing in a table is very easy, rather than how it is given in Broadsman. The reference for this video is Broadsman book. So we'll do it in the table wise. Criteria to enter any patient in phase 1 of the Wilk and Andrews protocol for non-operative rehabilitation of the shoulder impingement syndrome patient is positive shoulder impingement sign, that is by your all three tests. First one was your knees impingement syndrome test, second one Hawkins and Kennedy, and third one is your resisted external rotation. So the goals of phase 1 is decrease pain, decrease swelling, decrease inflammation, reduce the chances of muscle atrophy and maintain the flexibility. Active rest is given, definitely eliminate any activity which increases the symptom, especially your rotations, which are going to definitely lead to further more impingement of the muscle whichever is getting impinged already. Range of motion exercises to be performed in phase 1 is your pendular exercise, that is for your after pendular exercise will come your active assisted range of motion in the symptom free range with rope and pulley for flexion, and L-bar exercises for flexion and external rotation. We have not started abduction nor extension, so flexion and external rotation method. So this was your phase 1. Criteria for the patient to mark in phase 2 is decreased pain and symptom, increased range of motion, painful arc is present only in abduction, and improvement of muscular function is seen. What is the goal for the patient in this? Re-establish non-painful range of motion, normalize arthrokinematics, decrease the muscle atrophy. Normalizing arthrokinematics. Why we need to normalize arthrokinematics of the GH joint? Because we saw in the knees progressive stage of the shoulder impingement syndrome, first stage was edema, second stage was fibrosis, and third stage was osteophyte. So once definitely the stage 2 and stage 3 is achieved, that is fibrosis and osteophytic stage, definitely the arthrokinematic of the joint is reduced. So do not let the patient to suffer through all the three stages. So start with the arthrokinematics as well. Thus GH joint is mobilized anteriorly, posteriorly, inferiorly with grade wise depending on whatever is needed. Active rest in phase 2 is not given. Important thing in phase 2 is range of motion. Look at it, flexion and abduction for rope and pulley, whereas in phase 1 it was only pure flexion with rope and pulley. In phase 2, L-bar method has flexion, abduction and rotations, except extension, and so do not do circumduction. There is nothing related to circumduction in this sorry about that, in this protocol. Circumduction is not mentioned. Do not do extension. Coming down to phase 3. Look at the criteria. Pain and symptoms definitely reduced, active range of motion, full range possible, improved muscular function. Whereas the goals will be normalize the range of motion, where in phase 2 we just did active assisted range of motion, that is rope and pulley and L-bar method. In phase 3 we have to normalize it, and the second goal should be symptom free normal activity. All the activities carried out by the patient should be symptom free. The last one is improvement in the muscular performance. Active rest, none in the phase 3. Aggressive L-bar exercises, active assisted range of motion and continuous self-capsular stretching is very important. Self-capsular stretching is important in order to avoid the capsular obligate translation, because any injury we have seen in the frozen shoulder, any injury leading to the capsule on the posterior aspect, your humeral head is going to translate anteriorly. If the head translates anteriorly, already there is a lot of impingement, then definitely there is going to be your further more impingement. Okay, so hence continuous self-capsular stretches is very important in phase 3. Coming down to the next one, that is your these were the first part, criteria, goal, active rest and range of motion. The second part will be your joint mobilization, modality, strengthening and education. So once you're writing in the exam, you have to write 1, 2, 3, 4, 5, 6, 7 and 8 for every phases, that is from phase 1 to phase 5. Please mention these all things. In phase 1, in criteria, goal, active rest, range of motion, what did we see? Criteria we saw positivity, goal we saw decrease in everything, that is pain, swelling, inflammation, muscle atrophy and only maintain flexibility. Active rest, definitely eliminate all the provocating activities which increase the symptom. Range of motion was only pendular exercise, active assisted range of motion, rope and pulley for flexion and L-bar for flexion and external rotation. Joint mobilization, I mentioned already why joint mobilization is very important. In phase 1, grade 1 and 2 is given, only inferior and posterior glide. Only inferior and posterior glide. Modality for pain reduction, cryo, TENS, HVPGS, that is your high voltage pulse galvanic stimulation. Strengthening exercise, just start isometric with submaximal strength for ER, IR, internal rotators, external rotators, biceps and deltoid. Though deltoid is painful, though deltoid is known to be overactive, in the case of shoulder impingement, you have to strengthen deltoid. Coming down to education and activity modification, avoidance of overhead activity, reaching and lifting activity should be avoided. That was your complete phase 1. Talking down about phase 2. Let's revise the criteria, goal, active rest and range of motion. Criteria was decreased pain and symptom, increased range of motion, painful are present only in the abduction and improved muscular function. Goals will be re-establish non-painful range of motion. Whichever was painful, you have to decrease the pain. Normalize arthrokinematics, completely normal. The last one will be decrease the chances of forming muscle atrophy. Active rest in phase 2 is not given. Range of motion, we have increased the ranges. Look at it, rope and pulley, flexion and abduction, L-bar method for everything except your extension and circumduction. Coming down to joint mobilization. In phase 1, we had given grade 1 and 2, here grade 2, 3, 4. In phase 1, it was inferior and posterior glide, here it will be inferior, anterior and posterior glide. Also, combined glides, if required, are definitely given. Modality is same, cryotherapy, common in any kind of physiotherapy. Before treatment, before manipulating, before mobilizing, please make sure you give cryotherapy. Or if you want to achieve the relaxation, definitely you have to give HMP, that is hot mass pack. Post mobilization, definitely provide cryotherapy for your cool down effect. In phase 2, because of high grade mobilization, the patient might complain of a lot of pain. Hence, please provide him a good painkiller, that is your phonophoresis, using your ultrasonic method. Strengthening exercises, continue with the isometric. Initiate scapulothoracic strengthening exercise. I'll be covering about scapulothoracic strengthening exercise in the other video. For now, just remember, initiation of scapulothoracic strengthening exercise is done in phase 2. Also initiate neuromuscular control exercise. Education and training not needed in the second phase. Coming down to the third phase. Pain symptoms are definitely reduced in third phase. That's why you have put the patient in third phase is the main criteria. Active assisted range of motion is achieved in every direction except extension and circumduction. Definitely improved muscular function. Now the goals will be normalize the range of motion. No need of active assisted range of motion. But don't cut down the active assisted range of motion. Just remember, normalize the range of motion. Symptom-free normal activity should be achieved in this phase. That is, whatever he is going to do daily activity, that should be, the pain should be reduced. It should be symptom-free. The last one will be improved muscular performance. Active rest is not given in phase 3. Range of motion. Aggressive L-bar active assisted range of motion should be started along with the capsular self-stretch. In joint mobilization, nothing is done. If required, continue the same. If required, only continue the same. Do not lead the patient to the hypermobility syndrome. So only if required, give the glides. If not required, he can maintain the normal range of motion. Modality, usually the pain is reduced, not required. Strengthening exercises. In phase 1, we were focusing only on submaximal strength isometric. In phase 2, it was continued isometric, initiation of scapulothoracic exercise and initiation of neuromuscular control exercise. Whereas in phase 3, we are going to initiate isotonic exercise, that is your dumbbell program. Initiate serratus anterior, that is your protraction retraction muscle, that is your boxer muscle, and initiate tubing progression along with the arm ergometer. This is very important. So please make sure you know about arm ergometer and tubing program as well. Education is not given in this phase because the patient's pain is already maximum reduced. Now coming to the last 2 points, phase 4, phase 5. These are the last point. Criteria for phase 4 is full and non-painful range of motion in every direction except extension. We have not started extension. Do not do extension. No pain or tenderness. 70% of contralateral strength, that is your, if right is affected, 70% of the left shoulder strength should be attained by the right one. Goal in phase 4 is increased strength, endurance, power, neuromuscular control. Active rest and range of motion is none. So joint mobilization will be none, modality is none. Strengthening exercise, because we are dealing only with the muscle, strength, endurance, power, neuromuscular control. No need of range of joint mobilization. He has already attained it. So strengthening exercise will be isokinetic testing, IR and ER, that is internal rotation and external rotation, modified to neutral, and abduction, adduction, again modified to neutral. Slowly, gradually get it to the top. This was the first point, that is your isokinetic testing. Second will be your initiate throwers 10 exercise program if the person is athletic, and initiate plyometric if the person is normal regular individual as well. Education and activity of the activity modification in phase 4 is none. Coming down to the fifth phase, that is your criteria, full and non-painful range of motion. Everything is normal, no pain or tenderness. Isokinetic testing, that fulfills the criteria. Satisfactory clinical examination. Please remember, when we are talking about the last phase in every protocol, usually it is given definitely to the athlete, sometimes sedentary people, regular old age people or youngster. It is usually avoided because they don't need that much of activity of the shoulder joint as an athlete needs for that particular game. So goal will be unrestricted symptom free activity. If you want to perform phase 5 in normal adults who have got shoulder impingement syndrome, modify it according to the person. Joint mobilization and modality in phase 5 is none. Isokinetic testing, as we did it in phase 4, it was modified to neutral. Do it in the 90-90 position for internal rotation and external rotation. For initially 180 degree per second, gradually progress to the 300 degree per second as well. Same thing for abduction adduction. Initially we did it for modified to neutral. Now it is 180 degree per second and 300 degree per second. Coming down to initiate interval throwing program. Here it was initiated through a stem program in phase 4, whereas it is initiated interval throwing program in phase 5. So adjunctive therapy will be your pain reduction mainly throughout the phases. Manual and electrotherapy. In physiotherapy, manual will be your kinesiotaping, definitely to increase pace, reduce edema, reduce the muscular activity, inhibit some muscle, reactivate, facilitate the contraction of some muscle. That I have already dealt. If you guys have not seen the video, I'll put up the link in the description box below. Meconal taping is going to reposition the joint if you want to do the subacromial decompression, which is going to help the patient in primary cases. In primary shoulder impingement, definitely it is going to help meconal taping. Electrotherapy is reducing pain by TENS, ultrasound phonophorus, and matrix can be helped in order to reduce the spasm. Maintenance exercise program are your flexibility exercises, for that is your L bar, flexion, external rotation, self-capsular stretches, isotonic for supraspinatus, prone extension, prone horizontal abduction, therapeutic for internal and external rotation, neutral to 90-90 position because you are already trained for isokinetic device, D2 PNF pattern, Sarato's push-ups, and interval phase 2 for pitchers. Interval phase 2 for pitchers, again it is used only in the athletes, not in the regular individuals. So thank you one and all. Let's meet you all in the next video.